Hi everyone, and good evening, and thank you for joining us for tonight's update in partnership with St George Hospital. My name is Lauren Thomas, and I'm the CPD Program Officer here at CESPN. I'd firstly like to start tonight by acknowledging the traditional custodians and sovereign people of the land across which we work. I recognise the continuing connection to land, water and community, and I pay respect to elders past, present and emerging. I would also like to extend that respect to any Aboriginal colleagues who may be joining us tonight. Just some housekeeping before we start. This session will be recorded and will be available on the CESPN YouTube channel within the next few days. At the end of the webinar, an evaluation survey will pop up on your screens. Please complete this to allow us to issue your certificates of attendance. Tonight's webinar has been accredited for 1 hour of educational activity. We'll also submit that to RSCGP on your behalf. The chat box is also open if you have any comments and any questions, please put them through to the Q&A. We have online tonight, we have our GP facilitator, Dr. Martina Gleeson. She's a local GP and clinical lead general practice at the Southeastern Sydney Health Pathways, and she will be facilitating our Q&A with Dr. Zheng today. We also have Kylie Turner, who's the Chronic Kidney Disease CNC and member of the St George Hospital Integrated Care Chronic Diseases Working Party. She is also online tonight as well. And I would like to introduce Dr. Zheng, who's the Respiratory and Sleep Physician, Staff Specialist at St George Hospital, Sleep and Circadian Research and Clinician at Woolcock Institute of Medical Research. Thank you, Dr. Zheng.
Thank you. Just work out. Okay, you can see the slides okay?
Yes, we can. Thank you.
Okay. So I'll use 5 non-sleep apnea related cases to cover less frequently encountered sleep presentations that you might see in your GP practice. Although obstructive sleep apnea represents the bulk of your sleep encounters as well as our sleep encounters, it is important to recognize the clinical features of non-respiratory sleep presentations, as there's often a delay in diagnosis of these disorders, which can lead to poor quality of sleep, reduced quality of life, and other important clinical consequences. It is also important to know when a home sleep study is insufficient. And while the patient is waiting for formal sleep assessment, there are a few management considerations to be put into place. Okay, so I'll start with the first case. 34-year-old female, background anxiety, depression on sertraline, BMI 32. She's following up after a home-based sleep study for snoring and non-restorative sleep. This showed mild obstructive sleep apnea. There's some fragmentation of the sleep architecture. And it was also noted that she had frequent PLMS in the report, but it's unclear if they were leading to any arousals. Treatment of her obstructive sleep apnea was discussed. She declined CPAP or mandibular advancement splint and opted for a more conservative approach or weight loss management. However, she did mention broken sleep and difficulty with sleep onset due to RLS, which I guess the PLMS may have triggered that conversation. And that's occurring on most nights. So which of the following management steps will you take? Sorry, there's no poll options and I'm not going to give you an opportunity to answer it, but it's just some options to get you thinking. So would you see sertraline and seek an alternative antidepressant, commence an alpha-2 delta ligand, check ferritin, and then potentially consider replacement if it's low, commence low-dose pramipixole, initial trial of nocturnal magnesium or pre-bedtime magnesium magmin, any non-pharmacological treatment and approach, and just a mnemonic reminder of what counts as restless legs in terms of urge to move. Rest-induced gets better with activity and gets worse when rest again, worse in the evening and worse at night when you're lying down trying to sleep. Okay, so in terms of going through the options, so sertraline, so some antidepressants are associated with increased restless leg symptoms and PLMS on the sleep study. So usually mirtazapine is the worst. So most SNRI and SSRI, such as sertraline, worsen RLS, although sertraline appears to only increase the index on the sleep study, but doesn't appear to disrupt sleep so much. When it comes to any medication change with sleep medicine, we sort of get the patient to discuss with yourself or the treating psychiatry team, balancing the risks and benefit of changing things over or stopping treatment. So what about magnesium? So as you know, that's for leg cramps, and no evidence it works for restless legs, but some patients are on it. There's a placebo effect. If they think it works and it works for them, then so be it. There's sort of very little harm in them being on a small dose of magnesium before bedtime. So commencing alpha-2 ligand and pramipixole, so we're probably not at that stage yet to talk about pharmacotherapy. The first step, again, emphasizing in this case, is checking the ferritin and making sure they're adequately replaced. We'll talk about what target levels a little bit later. And then in terms of non-pharmacological therapy, so avoiding any caffeine, alcohol, nicotine. All of this is easier said than done. And then consideration of using distracting exercises, so Sudoku and things like that. Not engaging in vigorous exercise, particularly before bedtime. A lot of exercise fanatics get restless legs. And then warm bath, cold and hot compresses, depending what works for the patient. Okay, so what is the role of iron in restless legs? Sounds like something completely far-fetched. So the pathophysiology of restless legs is not fully understood, but it is thought that it is a relative brain iron deficiency. Hence, conditions such as pregnancy and end-stage renal disease, which is associated with systemic iron deficiency, also have higher rates of restless legs symptoms. And imaging studies and CSF sampling demonstrate that there are reduced iron indices in these patients. So low iron stores in turn lead to other, I guess, signal pathways in terms of low adenosine and dopaminergic dysfunction, which sometimes explain why some of our drugs that we use work in terms of working on these pathways, but addressing the iron deficiency would be the first step. So what is the optimal iron target? So I guess when I get pathology results back, or when the patient tells me that they've had bloods done, the iron level is normal, I always want to see what normal is for that particular patient. I think, DHM might have a cutoff of 30 micrograms per liter. The target is 75 generally, and sometimes in difficult patients, we might even try IV infusion, even if their level's higher than 75, to see if it helps. So this is the recent guidelines or recommendations from European, from the Journal of Clinical Sleep Medicine. So any patients with clinically significant restless legs should have their iron studies, including ferritin and transferrin saturations, tested. And then just a reminder for the patients, testing should be done where they haven't had their, avoided any iron-rich foods or iron supplements, at least a day or 24 hours before the blood draw. And then suggest supplementation of iron, either oral or IV, if the ferritin is less than 75 or the transferrin stats is less than 20%. If we're trying to get a trial iron and their ferritin is already above 75, then IV iron would be required. Okay, so what are some of the issues with oral replacement? So it's slow. So for patients with quite severe symptoms, and we'll sort of get to that a little bit later, it takes too long for the iron to be reaching the adequate levels or get into the brain stores. So it's not quick enough. There's issues of intolerance in terms of gastric upset and constipation. And then up here, I've got some of the tips from how to absorb iron. I'm sure you guys are all well aware of that. You can look back on the YouTube video if that's required. And then we discussed it may not increase ferritin to the above desired target range. So considering of iron, IV iron, so poor oral absorption or rapid response required when we need a ferritin level above 75 micrograms. And then there's there's a debate whether some IV iron formulations may have better entry into the central nervous system versus a hepatic breakdown or deposition. Most of the evidence is ferric carboxymaltose, but I think ferrous sig is what's first line or what's recommended from the hematology guidelines. So back to our case. So 34-year-old on SSRI, mildly, so BMI 32, class 1 obesity with restless legs. So further questioning, she does have menorrhagia. Iron studies showed a low ferritin of 27 micrograms per liter, transferrin sats of 14%, normal hemoglobin. She initially trialed oral iron, but poorly tolerated and ended up having an IV iron infusion. At the 3-month recheck, and again, we discussed how avoid any iron-rich foods before the recheck, as it could distort the values. It was adequate. There was symptom improvement. Her severity index has improved from severe to moderate, and she has been using non-pharmacological strategies, but ongoing reports of being unable to sleep due to having symptoms of restless legs on most nights. So which of the following management steps would you take? So this is a pharmacotherapy question. So alpha-2 delta ligand, low-dose pramipexole, dopamine patch, low-dose hypnotic, and low-dose opiate. So what she has is chronic persistent symptoms. And now the recommendation, first line is alpha-2 delta calcium channel ligand, so gabapentin and pregabalin, rather than dopamine agonists such as the pramipexole or one of the dopamine agonist patches. So that's come about after, again, a recent review recommending gabapentin or pregabalin with strong recommendation 4, and now conditional evidence, conditional against any dopamine, starting dopamine agonists as first line. The rationale for this is the issues with dopamine agonists. So there's a fairly decent chance of getting augmentation. So between half and 2/3 of the patient that you start a dopamine agonist, such as pramipexole on, will have symptoms of augmentation at 10-year mark. And it is difficult to treat. So some of the strategies to mitigate this, so discussion or informing the patient and asking about this every visit. What are their doses? How are their symptoms? Looking for signs of augmentation. So symptoms starting earlier, needing higher doses, and affecting other parts of the body. So the general pharmacotherapy strategy, if they have to be on the dopamine agonist or they opt to be on a dopamine agonist, is start low and remain on the lowest effective dose. Try to avoid increasing pramipexole to above 0.5 milligrams. And then the risk of augmentation is increased with low iron stores. So again, check the iron stores periodically. There's a risk of impulse control disorders, reported to be 10%, but likely higher. So likely underreported. So that's where collateral history may be important, and then repeated probing. So I had a patient who, on the initial review, mentioned, there's no impulse control disorder. Subsequent review mentioned that they had this addiction to super duper weed. They'll go through a whole box of this in 24 hours. And then the next time mentioned, issues with credit card bills and compulsive shopping. Some of the other impulse control, so hypersexuality, gambling, and compulsive eating. Again, mentioning this at the onset when you're about to start them on a dopamine agonist. Involve the family members if you're, monitoring for any unusual behaviors. And again, inquire, ask about it in the future, probe. So the alpha-2 delta ligands, although they're first line, they do come with their own side effects that I'm sure you guys are well aware of. So the options are gabapentin or gabapentin in a couple. With gabapentin, there's a nonlinear pharmacokinetics at doses above 600 milligrams. Usually we start at 300 milligrams. Usually they need a dose range between 900 to 1200, usually taken at a daily dose at nighttime. For pregabalin, 75 milligrams and gradually up titrate, usually around needing about 300 milligrams. and they have a smoother pharmacokinetics. If you need higher doses, you can split them in an evening dose and a pre-bedtime dose. Potential side effects, so they're all relative contraindications. I'm sure you're aware about the increased risk of low mood and depression relapse, suicide ideation, obesity. So that's something, again, talk to the patients about, monitor. There is a risk of weight gain in elderly, risk of worsening cognitive dysfunction, brain fog, gait, and falls. And then caution in some of our COPD patients and untreated OSA patients, as it is a respiratory depressant. Okay, so back to our case. She opted for pramipixole, worried about further weight gain and mood disorder. Commenced on 0.125 milligrams, and then gradually, eventually ended up on 0.5 milligrams for moderate to severe symptoms, and was able to adequately control symptoms. So, it is a very effective drug, generally speaking. Unfortunately, 2 years later, so she's now 36, she's come back, well, 18 months later. She had a cancelled afternoon LASIK surgery under local anesthetic. She was unable to stay still, so wriggling her legs, wriggling her hips. And so cancelled surgery, and then the ophthalmologist referred her back to your clinic. So she's began to have earlier symptoms, and on further questioning, she has been self-escalating doses and has gradually increased to 1 milligram per day. So which of the following management steps will you take? Recheck iron. You're going to split the doses, so early afternoon dose to cater for her eye surgery under local anesthetic, while continue 0.5 milligram, so we'll continue the nighttime dose, so 0.5 afternoon and then 1 milligram nocte day. Abrupt cessation of pramipixole, recognizing that she has features of augmentation. Trial a dopamine agonist patch. Trial alpha-2 delta ligand. Commence opioids. Redo diagnostic sleep study and reassess her periodic limb movement index. So what she has is, augmentation, so paradoxical worsening of restless legs. Occurs with a dopamine agonist, so increasing doses to achieve the same effect. Earlier symptoms, so at least 2 hours earlier than the previous baseline, spreading to other body parts, and again, shorter duration of effect with pharmacotherapy, and then longer time to achieve the same symptom control. So back to our options. So rechecking iron, yes, that will be worthwhile. And then, this is the type of a case where you may even consider a therapeutic trial, even if the ferritin is over 75 micrograms, as long as the transferring SATs is below 45%. So splitting the doses, it would be a short-term option to get her over this eye surgery if that's necessary and urgent. But as we discussed, not a viable long-term plan, as the dose would just continue to escalate. Abrupt cessation of pramipixole. So that could be considered for people who are having impulse control disorders with severe consequences. However, in the case of augmentation, this will cause severe rebound restless leg symptoms and trigger insomnia. So that's a no-go. Trialing dopamine agonist patch. So dopamine agonists are generally associated with less severe augmentation symptoms, but probably just as frequent. So again, no-go. Alpha-2 delta ligand. So it isn't a useful add-on combination option while you're monitoring for potential side effects. Commencing opiate. So actually, opiate is an add-on option, and it's an alternative monotherapy. But obviously, by that time, you should refer on, and even us, we would consider involving the pain specialist to assist with avoiding them from getting them off one addiction to go on to another addiction. But generally speaking, patients with restless legs do not. There isn't a significant escalation of opiates over time. So redoing the diagnostic sleep study, in this case, it's not relevant. Restless legs is very much a purely symptom-based treatment or assessment. So just a summary. So optimize iron stores, avoid abrupt cessation, and then consider referral. And then we talked about the treatment later, adding on alpha-1 delta ligand or having opioids as a backup option. You would not wean any dopamine agonists until you get the replacement drug or the combination drug to adequate therapeutic levels. And then you may very slowly drop it down. So I guess in her case, a 0.1 might drop down to 0.75, then 0.5 every 4 weeks or something, very slow, and reassessing her symptoms. Then there'll be a portion of patients, and probably close to half, that will not be able to be completely weaned and will need to stay on dual therapy. Okay, so take-home messages: iron, even consideration of early IV iron. I have to say, sometimes find it hard to organize IV infusions, but would be easier in the GP practice. Non-pharmacological approaches for mild symptoms. Dopamine agonists are no longer first line for persistent symptoms, but can still be used for intermittent symptoms. So that's less than 2 or less occurrences per week on average. And if used for patients already on dopamine agonists, remember to screen for augmentation, screen for symptoms of impulse control disorder. We talked about the maximum recommended dose based on our, the recent reviews. We talked about alpha-2 delta ligands, when to refer. Generally speaking, diagnostic sleep study is not necessary, but sometimes when we find PLMS on report, we may prompt or asking about restless legs and iron stores in general. Okay, we'll move on to case 2. We'll leave the questions to the end. So this is a 64-year-old male, background hypertension, obesity, mild obstruction for his COPD, and osteoarthritis. Follow up to home study for snoring, non-restorative sleep, and with the Epworth Sleepiness score of 10 out of 24. The reports come back with severe OSA with frequent desaturation, so AHI 44 events per hour, ODI 3%, that's the oxygen desaturation index, below 3% and below, which is 42 per hour, so decent hypoxic burden, and they had a nadir of 84%. Appropriately was referred to a CPAP provider to commence treatment. Although the reported snoring by the family has improved or resolved, the patient still reports non-restorative sleep and ongoing daytime sleepiness and fatigue. This is their download, so just bring your attention to the highlighted section. You can see they've got this is a machine-interpreted AHI, or reported respiratory event rate, so AHI of 18. There's a mix of what machine thinks is apneas versus hypopneas, so partial airflow reduction versus what it thinks is a complete airflow cessation, and then some central, some obstructive out of the respiratory events. So which of the following management steps will you take? Are you going to ignore the APAP download as the snoring has resolved? Refer to a sleep physician for a diagnostic sleep study and MSLT because they're still sleepy, CPAP titration study, bi-level titration study, or further interrogation of the original home study report, or change to fixed CPAP mode and then review in 2 months. So yes, the APAP potentially has resolved the snoring. So APAP is an auto-titrating CPAP mode, but does not address the underlying sleep quality issues. Referring to a sleep physician, so there's no indication of underlying pathological hypersomnolence. That would not be in the age group that we would consider likely. CPAP titration, yes, that's appropriate. Bi-level titration, that's infrequently used in OSA. It's only really for patients' intolerance of CPAP or if they've got hyperventilation disorders, which I guess so far the case hasn't suggested. Further interrogation of the original home study report, so it'll be useful if available, but I guess we don't have access to any of the raw data to clarify whether they had any central events initially. And then changing them to fixed mode. So unfortunately, the optimal pressure is not available based on the APAP download, although it could be something considered in terms of while you're waiting for a CPAP titration study, changing them to fixed CPAP might be appropriate. Okay, so what are the significance of the AHI reported on the download? So this is based on sensors that's inside the PAP devices, based on flow, the airflow profile, as well as any vibratory snoring. The auto-titrating PAP device uses that data to adjust the pressure to counter any upper airway obstruction. And the data stored and recorded as AHI. So apnea index, which could be central obstructive, hypopnea index, and then unknown. So the central or the clear airway index is based on the fact that the airway is clear, but there's no airflow. So they send out pressure signals to detect if the airway is open or closed, and sometimes cardiac oscillations, which will be present if the airway is open. Now, these sensors are different between manufacturers, so there's differences in definition and differences in response, and there's not much data on any head-to-head comparisons. In general, the PAP overestimates AHI at low values, but underestimates the actual AHI at higher values. So there's more scatter and underreporting when the AHI is elevated, such as in this case. So good correlation with manually scored events when the PAP AHI is less than 10. And if they have a low PAP AHI and good symptom control, we presume they've got adequate treatment and not necessarily put them through a formal titration study if there are no other concerning comorbidities. So what are the predictors of high residual AHI? So heart failure, cardiac risk, we'll come to this later in the case, mask leak, stroke, age, and then having a high initial AHI. So this patient went on to have a CPAP titration, and what this showed is that they had central sleep apnea events. So there's cessation of airflow, and there's a lack of respiratory effort. So that's on the pressure bands on the bottom. So why did they have that? So they have what is now termed treatment emergent central sleep apnea. So emergence or persistent of central apneas during treatment of obstructive sleep apnea. It's commonly associated with CPAP therapy, but also observed in non-PAP treatment of OSA. So mandibular advancement splint, upper airway surgery, and even tracheostomy patients. It occurs in surprisingly high number of patients, so 5 to 10% of patients. And in inpatient CPAP titrations up to 18%. So not a uncommon problem. So why does it occur? So the underlying mechanism may differ from one patient to the next. So it could be the side effect of the CPAP therapy. So that's the true emergent central sleep apnea patients. So they get better ventilation, improved VQ mismatch, so their carbon dioxide drops, and then that drops to the point where there's no signal for them to breathe. So that's the main mechanism of centrals is there's periods where the respiratory drive, usually from chemical sources, is absent. Overinflation of the lung triggering the Hearing-Burrow reflex, or the PAP machine itself is causing sleep disruption, and then having unstable sleep during periods of wakefulness and going back to sleep, they have unstable breathing. Or the patient may have an innate tendency for central, so the treatment persistent. So their OSA is treated, and once that's treated, the central sleep apnea becomes unmasked. This is a reflection that they have a high ventilatory instability. So their breathing pattern oscillates between underbreathing and overbreathing, and that's sort of an innate tendency of the patient, but they may also have other disorders that increase their risk. So cardiovascular disease, central nervous system disorders, and medication therapy. Or alternatively, these patients are completely misdiagnosed. You get a report that says severe OSA or severe sleep disorder breathing, but if you go in and look at their actual data from the original sleep study, they're actually more in favor of, more of a central flavor of events rather than obstructive events. So, and often, hypopneas in these sleep study reports are presumed obstructive. So if you have a central apnea index of 8, obstructive apnea index that's lower, and then you have a hypopnea index of 24, it might come down to a conclusion of severe OSA when, the hypopneas are also, central in nature. Hope I haven't lost you guys on that. But in essence, why is this important? Because it predicts poor CPAP acceptance and long-term adherence. So modifying treatment may improve their CPAP outcome. or PAP outcome or treatment outcome. So a portion of patients will resolve or may resolve and can continue on CPAP, but when to watch and wait and when to change treatment early is important. I guess, if a patient is intending to convert from renting a machine to buying a machine, and you're not giving them certainty whether their sleep disorder breathing will get controlled or not, there's, some financial concern with respect to that. Or if they ended up buying a CPAP machine and then later find out that it's not going to work and will need to escalate their treatment, that's going to be an issue. It does require more attention and treatment adjustments. So having an auto titrating mode and the use of respiratory pressure release will exacerbate this problem. So converting them to a fixed pressure might be a good idea while they get formal assessment. And then mask leak is a main driver, is also an important factor in terms of driving central events. So if you're leaking through the mouth, the machine's going to deliver more air and it's going to blow down the CO2 further. Okay, and so it's also important because it may reflect an underlying disorder that's undiagnosed. So cardiac dysfunction, so do they have underlying AF that's not detected during their sleep, or another state which results in poor cardiac output? Less common, it could be a brainstem disorder, and then medication side effect is also an important consideration. Are they on any other respiratory depressants? Or it could be undertreated. So if they're already known to have heart failure or atrial fibrillation, is this a marker that their underlying cardiac disorder could be further optimized? Okay, so going back to our case, so initial home sleep study for snoring, poor response with auto-titrating PAP therapy. And then the repeat sleep study showing a mix of obstructive and central events on the diagnostic, and then the pressure titration, which I showed, recommended a pressure of 11, but there was still residual central events, and that correlated with periods of atrial fibrillation. So this patient was referred to cardiology for AF optimization, so medication and cardioversion. Potential ablation, and then download 3 months later, improved tolerance and good sleep quality on a nasal mask with chin strap, and then a fixed pressure of 11 was sufficient and no further centrals. Okay, so the take-home points: a proportion of patients treated for OSA will develop central events. It can occur in other treatment modalities. The mechanism vary between patient and patient. It's not always clear, and it's important for for us to assess what might be the underlying driver, because the treatment outcomes and treatment options will be different. It's an important reminder to assess whether there's another disorder. So the central sleep apnea is almost never idiopathic. It's some other condition that's driving this. And it's important that we don't just, ignore it. It's a time and opportunity to find if something else is that might be important to treat. And then refer patient for sleep assessment and need a formal titration and potentially a repeat in-lab diagnostic. Okay, we'll move on to case 3. 72-year-old male, background hypertension and diabetes, previous cerebral vascular disease, but no residual deficits, essential tremor, depression on fluoxetine, and the patient's a retired actuary. Boredom by concerned daughter. The patient has been striking out at his wife, choking her, kicking her. His reports that he's dreaming that he was being attacked and was just being defensive. There's been episodes where he's fallen out of bed and fractured his wrist. He describes vivid dreams and nightmares. There's some arguing and screaming during sleep. So which of the following management steps will you take? Arrange a home sleep study to exclude obstructive sleep apnea. Refer to a sleep physician for a diagnostic sleep study. Refer to a psychiatrist for further mental health assessment. Report as domestic violence. Ask them to sleep in separate beds. Refer to a neurologist for further neuroimaging and assessment. Okay, so what the patient is describing is dream enactment behavior. So active, often emotionally charged dream content that break through normal REM sleep motor suppression. So during REM sleep, which is usually the dreaming sleep, our skeletal muscles are paralyzed. Hence, why obstructive sleep apnea is more common in REM sleep, because we lose some of the upper airway dilator muscle function. Also, where sometimes patients come to you and report that they've woken up and feel like they've been possessed or squashed or choked during sleep. So what they're describing as sleep paralysis. So that's waking up in REM sleep and noticing that they can't move their body. So in this case, there is motor action or motor function in REM sleep. There's purposeful limb movements and sometimes vocalization, so shouting, swearing, and crying. And sometimes it's pleasant dreams, but often it's kind of a negative, and what I describe as persecutory type dreams. They're being attacked, they're being chased, they have to defend themselves. And what differentiates this from non-REM parasomnia is that they are able to recall the event immediately after it takes place. So it may not be the next day or when you ask them a few days or a few weeks later, but generally speaking, at the time of the event, they're living their dream, which is different from non-REM, which often is no awareness and no recollection. It can occur with REM sleep fragmentation. So if they've got circadian disruption disorders, circadian disruption, they've got obstructive sleep apnea, they've got periodic limb movement disorder. So these are the movements that occur during sleep leading to arousals. It's a feature of narcolepsy. And then patients with post-traumatic stress disorder or trauma-associated sleep disorder, this can occur. And again, sort of a similar theme with medication. It can occur or more frequently identified in patients who are on antidepressants. And then suvorexant, or Balsamra, so that's a orexin antagonist. They're used for insomnia. So this is something I see that's increasingly prescribed. So one of the things that you have to remind patients, along with other side effects, is that they might experience dream enactment behavior. So what are the dream enactment behavior is also a defining clinical feature of REM behavioral disorder. So the direct disruption of the brainstem nucleus that maintains atonia of REM sleep is seen in this instance. So suspicion of RBD, so that requires an in-laboratory diagnosis. There's a specific protocol which will put more wires on their upper limbs as well. And we're looking for evidence of REM sleep without atonia. So this patient is in REM sleep, and you can, in their polysomnogram, the eyes are flickering. And you can see they are acting out physical movement when they should have skeletal muscle paralysis. And you can see this patient is hitting something. So we need that as part of the diagnosis of REM behavioral disorder. And later we'll discuss in some of the Parkinson's disorder, this feature is also useful to assist the neurologist with that diagnosis. The sleep study is also useful to exclude other sleep pathologies, so REM OSA, and differentiate from mimicry, so non-REM parasomnia, sleep seizures, or is it just a limb movement disorder? The patient's being, or the bed partner's being kicked because the patient's just periodically, rhythmically kicking their leg. So going back to our questions in terms of management steps, so arrange for a home sleep study. So we'll not provide useful information about dream enactment behavior. So if you're going to do a sleep study, you might as well do it where all the questions are going to be answered. Refer to a sleep physician for a diagnostic sleep study. Yes, we'll need features from an in-lab sleep study, as we just discussed in the previous slide. Refer to a psychiatrist for further mental health assessment. So dream enactment behavior can be associated with post-traumatic stress disorder and trauma-associated sleep disorder and antidepressant use. So that might be a consideration, although in this case, I guess I didn't mention or delve into whether they've got any underlying PTSD. Reporters DV, so in this case, dream enactment behavior is not intentional. I guess we don't know for sure, but generally speaking, the patients are completely shocked that they're doing something like this and completely, are apologetic. So ask them to sleep in separate beds. So that's an appropriate safety option. We'll discuss that a little bit later. refer to neurologists for further neuroimaging assessment. So again, we'll need to confirm that the presence of RBD first. So in case, I guess, unless they have other features of neurodegenerative disorder, you would first do a sleep study, and then we'll talk about when it's appropriate to refer to a neurologist. Okay, so management principles of treatment active behavior, or RBD. So the first thing is safety, safety, and safety. So it's important we advise the patient or counsel them on keeping or creating a safe sleep environment. So in this case, this patient's been heading out at his wife, so not just the patient, but the bed partner, and then he's also fallen out of bed and fractured his wrist. So we would try to reduce any REM sleep disruption. So that goes back to having a good sleep routine, making sure they've got enough sleep, and treating any contributory primary sleep disorders. So again, sleep apnea and periodic limb movement disorders. Minimizing any provoking substances, so antidepressants and alcohol. Again, our antidepressant is a discussion whether, these events occurred even before the start of antidepressants, or is antidepressants a bystander, and is it safe to get them off the antidepressant therapy. So psychotherapy. So there's some evidence that these type of treatments are effective for post-traumatic stress disorder, and to address if they've got underlying insomnia, which can again fragment their sleep. The role of pharmacotherapy, so limited evidence, we would still give it a go. Melatonin, the doses would be much higher than what's used or attempted for insomnia, or jet lag, or shift work, or circadian rhythm disorders, so often above 6 milligrams. Clonazepam would be the second line agent, and then I guess caution when it comes to elderly patients, which unfortunately most of the RBD patients would fit into that group. So there's a debate about who to treat and how to monitor treatment efficacy. As we really rely on history, there's not much great markers that we can use, say, compared to obstructive sleep apnea, to say how effective our treatment is. If they're still having events, is it reduced in frequency because of the medication? Or if they're not having many events, is it because of the medication? Or is it, they're just not having many events? Or the bed partner's moved out and no one's reporting it? And then we'll talk about, do we disclose the associated neurodegeneration that comes with REM behavioral disorder? Okay, so sleep environment optimization. So 8 in 10 patients who have RBD will have sleep-related injuries. 2/3 themselves, 1/3 their bed partner. 2 in 10 will have a lifetime incidence of head injury, and then there's a 1 in 10 chance, or over 1 in 10 chance, of them having severe injury, needing hospitalization. So this is a Google image search of a bedroom, and some of the things to consider. So anything that's next to the bed, they can grab and use as a weapon. The bedside table, any sharp edges, they can knock their hands or head into. So potentially considering moving, I guess not possible in this case, but having padding or moving the bedside table away from the partner. Anything heavy, sharp, or blunt instruments should be stored away. Glass, they can jump or whack their hands through it. So any glass, any drawers with glass on, make sure the bed's not right next to the window. Wooden floorboards, so or even carpet falling out of bed, so whether you have extra padding, pillows there to cushion their fall. And then any trip hazards, and again, anything that could bump into. So we briefly alluded to in terms of neurodegenerative disorder. So there is prognostic significance of having REM behavioral disorder. There's a strong evidence that RBD is linked to the development of neurodegenerative disorders. So synucleinopathy. So that's Parkinson's disease, Lewy body dementia, multi-system atrophy. So it's a broad term for a group of disorders where alpha-synucleinopathy is the primary misfolded protein, and the underlying mechanism is not fully understood, but basically it sort of spreads between or along the nervous system pathway, affecting different parts of the body. So there's clumping of the protein, forming balls at synapses. It was discovered by Dr. Lewy, hence the Lewy body termination. Now, in RBD, what happens is it's affecting some of the spinal motor neurons, so that's how they end up having REM behavioral disorder. So the things that suppress movement is lost, or the nerves that suppress movement is lost. So there's activation and leading to RBD. Now, if it's further up, it can affect cognitive function, and then the cerebellar area in terms of the motor function or motor symptoms that comes with Parkinsonian or Parkinson disorder. So idiopathic RBD, so that's RBD that's not due to drug or post-traumatic stress or narcolepsy, has a conversion rate to Parkinson disorder of 40 to 80% over 5 to 15-year period. In terms of risk factors for phenoconversion, so age of diagnosis. So if we break it down per year, it's easier for discussion and prognostication. So over 76% per year. It doesn't sound that bad once you break it down per year. And then 50 to 60, less than 1%, and under 50 is almost, case reports, very infrequent. So I wouldn't even, bother mentioning any consideration of neurodegenerative disorder in that bunch of patients. And again, as we discussed, if they are antidepressants or there's a psychiatric diagnosis, probably that's the underlying cause rather than idiopathic, and hence less likely that they will develop a Parkinson-like disorder later in life. Some of the prodromal features, so some additional questioning that might allude to a potential concern that there are other parts of the nervous system is affected, more likely to progress. So sensory, so loss of smell, loss of color vision, autonomic features, so constipation, urinary incontinence, any postural dizziness. We talked about cognitive dysfunction, and we talked about motor features, which will come with a neurological exam for Parkinson's. In terms of ethics of disclosure, at this stage, there is no treatment to prevent, idiopathic REM behavioral disorder from progressing into Parkinsonism or dementia. So there's no available neuroprotective therapy. However, there's a lot of research. So there's an issue of non-maleficence in terms of sharing knowledge of IRBD, which is going to bring on stress, anxiety, having been told a diagnosis that at this stage there's no treatment for. However, that's need to be balanced against truth-telling and autonomy, so open disclosure and right for patient self-determination. And oftentimes, and particularly these days with Google and AI, they're likely to do their own research and will come across quite damning information. So having to go through the per year risks or other features that might help prognosticate would be useful than them finding out the potentially worse information online. And it may be useful for their future life planning and retirement planning. And then, although there's no treatment available, there is a lot of research interest in this area, so able to offer them enrolling in early clinical trials and being monitored. So the favored approach would be to just mention that this will be consistent with REM behavioral disorder, and then wait to say that it's associated with other conditions and see if they want to know more. Okay, so going back to our case, so their sleep study confirmed they've got moderate sleep apnea. They try CPAP therapy, but there was still REM sleep with atonia on their titration study, and the patient had modified sleep environment. Now they're sleeping separately to their wife. So other things you can consider is like a barrier pillow, one of those long elongated pillows, or sleeping bags. And then there's these alarms that if the patient get up, it triggers the radio alarm to speak in their partner's tone in a reassuring manner to calm them down. So sleep diary would be useful if they are considering pharmacotherapy, just to monitor the frequency of events. And the patient was happy to be referred to neurology for further assessment and monitoring, and then if there's any relevant trials. Okay, so take-home messages, sort of appreciate the features of REM behavioral disorder, which is, dream enactment behavior, and then being aware of any prodromal features. They'll need an in-lab sleep study for diagnosis, and we talked about treatment goals in terms of safety of creating optimizing their sleep environment, screening for comorbid disorders that might disrupt their sleep, and then we talked about the role of pharmacotherapy. Okay, case 4, 25-year-old female, background anorexia nervosa. Again, all my cases have anxiety, depression, fluoxetine, recent assessment for ADHD, pending outcome, referred for excessive daytime somnolence while they're still waiting for the ADHD outcome. So over 6-year history, their Epworth sleepiness score when they did it in your clinic was 17 out of 24. Their sleep time, reported sleep time was 9:30 to 7, so 9:30 p.m. to 7. Short sleep latency, slightly broken sleep, and they get vivid dreams, frequent sleep paralysis, visual hallucinations with their sleep onset. So that's generally, shapes, and then occasional dream enactment behavior. Previous complaints by the high school teacher for being inattentive or daydreaming, difficulty staying alert and completing tasks during the day, hence, the whole ADHD assessment. They've got bruxism, not aware of significant snoring, examination unremarkable, normal BMI, so not a strong suspicion of underlying OSA. So which of the following management steps would you take? Diagnostic sleep study, sleep diary, blood pathology, neuroimaging, stop their fluoxetine, and then or await the outcome of their ADHD assessment. Okay, so already mentioned that they had a low pretest probability of significant sleep apnea. So if we're going to do, considering an MSRT in this case, in that we think they've got a central disorder of hypersomnolence, i.e. narcolepsy, we might as well do it with the MSRT, which is a requirement. Sleep diary, so that would be useful, and it would be essential to exclude any circadian rhythm disorders, sleep duration, and if they have restricted nighttime sleep, they're sleepy because they're not sleeping as much at nighttime. We generally deal with actigraphy because that gives us more objective data whether they're truly asleep and whether the sleep diary is accurate. And we ideally ask them to do it during a period of unrestricted sleep, so they've got a break from their work or they're on their school study break. But oftentimes it may be difficult for the patient to do that. If they have a week off, they want to go on holidays and want to stay awake rather than spending their whole holiday sleeping. Blood pathology, so exclude any systemic or secondary causes of hypersomnolence. And then neuroimaging, we would consider if we suspect is due to secondary to an intracranial pathology, but I understand that has to be self-funded MRI. Stopping the fluoxetine, so again, only if it's safe to do so. And why would we want to do that? We would do that before the sleep study. And so sometimes we would ask your assistance or opinion whether, and your guidance in weaning them off their SSRI or antidepressant before the sleep study. Ideally, at least 2 weeks, but preferably 4 weeks, depending on their half-life, before the MSRT, as those antidepressants can be a REM suppressant, so masking features of narcolepsy on this daytime sleep study. Awaiting the outcome ADHD, so sometimes the features of ADHD may be due to underlying hypersomnolence disorder. And I guess, I don't have any data, but subjectively I feel that a lot of the ADHD are sleepy, but they also have symptoms of ADHD. So I don't know if there's an association between the two disorders, but also there's a chance that patient may be mislabeled as ADHD and they actually have an underlying central hypersomnolence disorder. So the pathophysiology of narcolepsy, they got loss of orexin-producing neurons. So orexin stabilize wakefulness and prevent inappropriate transition to sleep, and it's a REM suppressant. So the loss of orexin means your on-off switch is broken, so they're more easily waking up during REM sleep and more easily falling back into REM sleep, such as during daytime. So the features are hypersomnolence and features of REM intrusion. So what are the features of REM intrusion? So hallucinations, so visualizing things when they're falling asleep or waking up, sleep paralysis, the dream enactment behavior, And I guess, vivid dreams might be a feature. And in terms of the daytime feature, that would be the cataplexy. So REM occurring during wakefulness or during periods of unintentionally. So some of the helpful questions in terms of detecting possible narcolepsy, getting an idea of how sleepy they are. They tend to be a lot sleepier than the sleep apnea patients. Their nap quality that help us differentiate if it's narcolepsy or idiopathic hypersomnolence, and then asking for features of REM intrusion. So that's, vivid. Do they dream during their naps? Do they, hear, see, feel things when they're falling asleep? Are they waking up feeling they're stuck and unable to move? And have they sort of fallen over with when they're laughing? So recognizing cataplexy, so that's a sudden loss of muscle tone. So what differentiates this from seizure disorders, from syncopes, is that there's preserved consciousness. So this person, sorry, was told a funny joke, and then their muscles loses tone. It could be partial or full. In this case, she's fallen over, so it's a full event. But you can see her eyelids are drooped down. There might be slight slurring of the speech. So that the subtle signs might get missed. And they're not always as drastic as slumping to the ground. This feature of cataplexy is pathognomonic for narcolepsy, type 1 narcolepsy. There's very little other conditions that cause this. Oops. Okay, so investigations, we've sort of mentioned this. The diagnostic sleep study preceding the MSLT is to screen for other things. We talked about the actigraphy and sleep diary to exclude lack of sleep or abnormal timing of sleep. MSLT to confirm their pathological hypersomnolence. And then there's other testing, more for us to trying to figure out if it's a type 1 narcolepsy or if they've got atypical features that we're trying to prove that was an actual cataplexy. In terms of treatment, the main thing to highlight is Australia. We are lacking in what we can give and use. So at the moment, it's just amphetamines and modafinil. And then for patients with cataplexy, we might, put them on lamotrigine or venlafaxine. But potentially in the future, these orexin agonists might come to play, and you can see they have amazing outcomes in terms of improving their sleep MSLT scores. So improvement of, I guess, basically virtually normalizing their not MSLT, sorry, their wakefulness tests. However, at this stage, it's IV, there's liver toxicity, there's more research in this area, just watch this space. So other considerations, so stimulants monitoring, would ask your assistance in terms of blood pressure monitoring if they're not checked in the clinic face-to-face every 6 months, a baseline ECG, and monitoring for any cardiac side effects. Mood, so potentially increasing anxiety with amphetamines. Appetite, so it's a, appetite suppressants, so monitoring their weight. And then side effect management in terms of making sure they're adequately hydrated, and then timing their dose. So by definition, having narcolepsy or idiopathic hypersomnolence, they have to have a conditional license. And then contraception, pregnancy, breastfeeding is an important consideration because the medications can interfere with the efficacy of oral contraceptives. So we would ask the patient to come speak to you about alternative options. So basically any steroidal contraceptives are less effective because it's a cytochrome inducer, but intrauterine device, copper and depots are okay. Pregnancy, so modafinil is category D, so they will need to come off it for any planned pregnancy. And then dexamphetamine, there's a theoretical risk of neonatal withdrawal and uterine growth retardation, and both can be transferred across via breast milk. If they do have cataplexy, again, it's fairly rare to be observed. Again, that's going to be an issue when it comes to driving, swimming, and then safety considerations. And then non-pharmacological treatment, so optimizing their nighttime sleep. There's an increased risk of sleep apnea in narcolepsies, and there's weight gain in narcolepsies, increased metabolic disorders, and then daytime napping would be prescribed for narcolepsy, and then any letters for their work and study place to give them opportunity to sleep. So this patient was confirmed to have narcolepsy, that 2 SORANTs, sleep onset REM periods, commenced on modafinil. Fortunately, they're a learner license. We generally try to steer them away from commercial driving. Had the contraception pregnancy discussion. They'll have ongoing monitoring via you guys with respect to blood pressure. So take-home messages: not all sleepiness equals sleep apnea equals diagnostic sleep study. Being aware of the features and asking about REM intrusion, and then referring them for in-lab assessment. And we discussed the limited available therapies and some of the important treatment considerations. Okay, last case, which will be quicker. I'm sorry, I've gone over time.
Zheng, 28. Just a reminder that I think the session's supposed to finish at 8:30 and it's now 8:33.
Okay. Yeah. So should we just stop there?
That might be the best. I mean, unless people want to put a vote in the question and answer for you to keep going, I think it might be best to give people. There's no questions that are open at the moment.
Okay, sure.
So unless I think what I might like to do is give people 30 seconds to put a question in if they've got one, and otherwise we might draw it to a close. I don't see any evidence of people typing. It's been a very comprehensive presentation and an invitation to think about what else might be going on and not assume that all sleepiness is because of obstructive sleep apnea. So I found it very interesting, and thank you very much for your input. I can't see any more questions. There was one asking us if there would be a recording, which there will be.
Okay.
So, Kylie, did you have anything to add, or Lauren?
No, I don't think I've got anything to add. Just the next session, which I think Lauren advertised, which is the one on the 20th of May, which is the face-to-face session.
Yeah, I'd really encourage people to come to that. We've got some good speakers and some good themes, quite topical. So really think about coming. All right. Thank you so much, Dr. Zheng, and thank you, Lauren.